Well, an infected fracture, as I said, most of the time is the result of surgical intervention. So if they've done a repair to fix the fracture, the first thing you have to think about is when was the initial surgery and when did the infection present. So if it's fairly acute, meaning within the first 3 to 4 weeks, that's actually a good sign because there's a good chance you can actually eradicate that. The second thing you look at is how stable, let's say they put a plate in your leg, how stable is the fixation? Is that plate providing very rigid fixation? Because if it is, then oftentimes you can leave the plate, clean out the infection, and even though the plate is probably colonized, the body defenses are still able to fight it off long enough until the fracture heals. We do know, even in the case of a contaminated fracture, that if you have very stable fixation, the bone will go ahead and heal in spite of a low-grade contamination. So assessing the degree of stability of the fracture is very, very important. If, for instance, the plate is loose or the rod is not providing any stability, it's actually fighting against you. That instability prevents the body's normal defenses from helping you. So that plate and the instability has to be removed. So most of the time, in an acute fracture where the fracture fixation is rigid, you can treat it and leave the fixation in place. The bone will go ahead and heal. You may later have drainage coming from the colonized hardware, but then you can take that out and everything is fine. That's opposed to a situation long term where, let's say you had a plate in, the plate is broken, it's 2 years down the road, and now you've had drainage off and on. At this point, because there's no stable implant, that hardware is actually hindering you and acting as another nidus for infection. So not only do you have to take the hardware out that's not providing any stability, you also have to take that dead bone, the infected bone out as well, essentially establish a healthy biologic envelope, and then start the whole process over. Re-bone graft it, replate it, et cetera, et cetera. But the first thing you have to do is put the biology back to a healthy, stable wound before you can proceed.